Hi, everyone. My name is Justin Schweitzer. I'm an optometrist at Vance Thompson Vision in Sioux Falls, South Dakota, and had the opportunity to speak at Optometry's meeting 2026 in Phoenix recently. And we had a lecture that had a jam-packed room talking about secondary glaucomas. The title of the lecture was called The Secondary Silent Thieves. And really, I covered a variety of different types of secondary glaucomas and the nuances of how these can be a little more challenging at times to treat than our traditional primary opening glaucoma. I covered pigmentary glaucoma, pseudoexfoliative or exfoliative glaucoma, steroid-induced glaucoma, uveitic glaucoma. We also touched a bit on angle closure glaucoma, both acute and chronic. Each of these types of glaucomas, in their own unique ways, need to be managed differently. These types of glaucomas oftentimes are aggressive. Unfortunately, patients lose sight quickly from these types of glaucomas. So it's just imperative as optometrists that we're comfortable with not only diagnose these in a timely fashion and knowing, how to make the diagnosis, but as importantly, what are the treatment options for these patients? Is it always surgery? Do drops work better? Does SLT work better? And we covered that throughout this lecture to really hopefully give everyone that was in attendance the opportunity to go back to their clinics on Monday and be able to make the right decisions for these types of patient types. Really enjoyed my time at Optometry's meeting in Phoenix and enjoyed even more spending time with colleagues talking about secondary glaucomas with all the interaction and the conversations around it. So thanks so much for listening.
So, what are some of those most commonly missed signs that should raise suspicion for secondary glaucoma rather than primary glaucoma?
Yeah, great question. So when we think about, for example, pigmentary glaucoma, if we're not taking a close look at the corneal endothelium, looking for pigment on the endothelium or the classic Krukenberg spindle, if we're not using our goniometer to take a look in the angle to look for a heavily pigmented trabecular meshwork, or if we're not doing retroillumination to look for transillumination defects, you will miss pigmentary glaucoma or the pigment dispersion syndrome. It's the same thing with exfoliative glaucoma or pseudoexfoliative glaucoma. We have to be intentional at looking at the lens very closely because sometimes that classic pseudoexfoliated material won't be easy to see on the lens. But if we're looking for it, we're aware of it, we have a suspicion of it, we could pick these things up and specifically that one and make the right decision for our patients.
You had mentioned that this was a packed session. What were some of even a question that you think is imperative that all optometrists know the answer to that was asked?
The questions that kept coming up again and again, and I tried to address them throughout my lecture, was what's the best way to treat someone that has pseudoexfoliative glaucoma? What's the best way to treat pigmentary glaucoma? When we look at the literature around this, we had a discussion on this. When we think of exfoliative glaucoma, because it's on the lens, if it's a patient that even has an early cataract, visually significant but early cataract, getting the lens out of the eye is critical. That will help hopefully slow down the disease process. And we compare minimally invasive glaucoma procedures with the surgery. There's other options as well, but getting the lens out. Pigmentary glaucoma, we talked about the role of selective laser trabeculoplasty and how that can really help to lower intraocular pressure in these types of patients because of the way that the laser works, but also understanding that using SLT and pigmentary glaucoma, you have to be aware of pressure spikes. So those are the types of patients I bring back a little earlier after I do the SLT, a week or two rather than 6 weeks to make sure that we don't have an IOP spike, but knowing how effective it can be in managing these types of patients.
So, how do you approach co-management in patients with complex secondary glaucoma, and what does a successful co-management relationship look like in that case?
I think in general, successful co-management is all about communication, whether it's glaucoma, whether it's cataracts, whether it's glaucoma that needs surgery, which is what we're kind of touching on now. You want to work with people that are like-minded. What I mean by that is get to know the surgeon in your community that is doing MIGS procedures, that's taking cataracts out, and make sure that they have the same values and mindset that you do. Tell them that you're comfortable with managing glaucoma, with managing these secondary glaucomas, but obviously you're not going to take the cataract out as an optometrist. You need their expertise in that. And so educating the patient is the other big piece on really successful co-management as an optometrist. You need to spend time educating your patient on what to expect when they go to that surgical center with the cataract surgery, with the procedure that's going to be done. A well-educated patient makes it easier on the surgical center side. And then being in a surgical center myself, from our end, it's critical that we communicate back to the optometrist that is sending a patient to us. We need to take the time to communicate with what procedure do we do? Why did we do it? What's our goal intraocular pressure for that patient? The communication piece back and forth is critical because I think that when there's a breakdown in the communication on both sides, it leads to a really bad experience. And the experience that it's worst on is the patient, number one, but eventually the optometrist and surgery center relationship starts to break down as well. And again, that doesn't help anyone, the most important people, the patients.